So this is a case, came into my practice, referred 48-year-old man with mitral prolapse. His murmur was first heard 3 years before he was referred to Mayo. Physically active, no cardiac symptoms at that time. He was described as having a 3/6 mid to late systolic murmur 2 years before. And his mitral prolapse, he was graded as having 2 to 3 out of 4 regurgitation by outside echocardiography. And you can see the diameter of his LV was 56 millimeters in diastole, 30 in systole, and his ejection fraction was 74%. And he was exercised and got his VO2 was 124% of predicted. So he had 6-month follow-up echo just because that was the first echo that they had recognized the mitral prolapse on, and he had no change in the appearance of the valve at that point in time. LV was essentially the same, and the murmur was still mid to late systolic. And then a year ago, so another 6 months go by, and he's brought back out at the outside facility for another echo, and the valve looked unchanged. It was prolapsing still. There was still the same amount of regurgitation by qualitative assessment. His LV looked essentially the same in terms of the measurements. He wasn't having cardiac symptoms, and on exam it was a mid to late systolic murmur. And he just expressed interest in coming to us. The center he was at didn't have surgeons that performed mitral valve repair, and he knew that that might eventually be the outcome of his disease process. And so he requested to come up and start following with us, and I saw him for about a year after he had had his last echo. So when I saw him, he was very active physically. He wasn't having any kind of cardiac symptoms. You can see that he did have a family history of coronary disease, no family history of valve disease, and really no other coronary risk factors. And this is his physical examination. And this was, I'll just leave that up there. And then laboratory tests were pretty unremarkable, including a BNP that was 45. And this is what our echo looked like. So this is peristernal long axis, and you can see his heart's a little vertically oriented, so we don't get quite a rounded appearance on the short axis here, but that's what we get. And then here is with color, peristernal. And there's his, if we just look at the linear dimensions, he's got a 63 millimeter in diastole, 42 in systole. That comes with the Quinones method. That's an ejection fraction of 60%. Here's apical long, with and without color, or without and with color. Apical 4, without and with color. There's his pulmonary vein, right upper pulmonary vein signal. So I'll just bring up one of the teaching points, and you're probably all aware of this already, but the guidelines, the ACC guidelines were renewed in 2017. Actually, Dr. Rick Nishimura, who works with us, is the chief on that writing group. But they didn't change this from the original 2014 recommendation, and that is that mitral valve. He's an asymptomatic person, so the question is how much mitral regurg does he have? Because even if he's asymptomatic, if he has severe primary mitral regurg or myxomatous mitral disease, and if the likelihood of successful and durable repair is very high at a center of excellence for heart valve surgery, then that's a class 2A indication for sending him on to surgery. So how much MR does he have? We'll just vote, Jeff. If mild is 1, moderate is 2 out of 4, moderately severe 3 out of 4, severe 4 out of 4, or need more information. before. So a lot of people feel that it's severe, so that's really good. What would you do if, right now with the patient? So now the patient's gone for their echo, you've reviewed all that, reviewed his history, what do you recommend? Should we continue to follow him? Should we refer him for mitral valve repair, or should we do a TEE before deciding? TEE before deciding. Okay, and 32%, so 32% would refer for mitral repair, and 63% a TEE before deciding. Okay. Well, we actually, I think this is the point, one of the points I'm trying to emphasize is if the patient's asymptomatic and they have primary mitral regurgitation, then for our proper clinical decision making, we have to be as confident as possible that we know how much mitral regurgitation they have. We no longer wait for symptoms in these situations. And so one of the ways we can be confident, there are a couple other things that showed up there that I know you picked up on and properly called this severe, but we like to, if we can, go beyond that with the surface echo and do actual quantitation. And so he had an ERO that was 0.59 centimeters squared and a regurgitant volume that was 88 cc's. And just to show you, we did a, here's the, you have to look, we know the jet came over here toward the atrial septum and aortic root, so we know that it's going to originate over here, and we shift the color baseline, and then that makes the flow convergence really obvious here. And we're at 35 centimeters per second, so we do a few cycles. We want to catch this on the T wave or just after. That one was almost a centimeter, just about a centimeter, 1.1 centimeters, 1.27. We just averaged all those. We have a nice CW velocity profile here, and then we use the velocity in the TVI to calculate, as you know, the ERO and the regurgitant volume that I quoted. Now, the other thing was that the other clue that he had severe regurgitation is this, that he has an enlarged left ventricle now. And it's interesting that he consistently had about 55 millimeters on all of those other echoes, the last of which was, I believe it was about 9 months before he actually saw me. And so what happened to his valve, I think, happened in between the time he had his last echo and the time that they referred him up to me and I got him in for the consultation visit. And so he now truly has a larger ventricle than he had before. We did do strain on him. We're kind of interested in that to see if that predicts ventricles that might be on the verge of tilting over into dysfunction. His left atrium was large. He had a normal right ventricular systolic pressure. So this was our report, and I think many of you noticed that on several of those images it looks like there was a ruptured cord. And so we thought that was a flail P2 segment that he had, and had the large regurgitant volume. He had the systolic reversal in the pulmonary vein that I think a lot of you noticed to vote for it being severe mitral regurgitation. So we sent him, he didn't have many risk factors for coronary disease, so we sent him for CT coronary angiography, and he had normal images. He was very interested in doing his surgery, having his surgery performed robotically, and so he had the usual CT assessment of his vasculature, and that was appropriate for his vasculature was appropriate. So I didn't actually send him to TEE for a diagnostic TEE. He had the TEE pre-bypass. Now, if I had any question about the severity beforehand, I would have sent him for a diagnostic TEE to make sure he had severe MR. But in this case, you can easily see the flail segment, the ruptured cord. You can see, again, the eccentric jet of regurgitation, and here you can see the nice zone of flow convergence that correlates with the flow convergence that we use for the Pisa hemisphere. Nice 3D, you can see there are actually multiple ruptured cords there to the P2 segment, and he's got a fairly broad jet there. That's his LV from transgastric. So this is the repair, and I might ask Dr. Schaff just if you would just comment on the typical Mayo repair for P2 flail.
Yeah, in general, Buzz, the repair would be a triangular excision of that unsupported segment And then we use a posterior band annuloplasty for most of the patients. Now, some surgeons like to plicate it. There are other techniques for repairing the prolapsing segment, but if it's a posterior leaflet, most of the time we resect it or plicate it and not put in artificial cords.
Thank you. Yeah, and so that's exactly what he had, this triangular excision with the primary suture repair then of these edges and then the posterior annuloplasty band. And I won't ask Hartzell to comment on this because he didn't have anterior, but in your handout I put the techniques that are, a technique that can be used for anterior repair. So the surgical findings were that he had redundant leaflets, several ruptured cordae to the P2 scallop and a flail, and then he was also found to have a little cleft between P2 and P3. So he had the procedure that Dr. Schaff just described, and one little modification is since he had a little cleft adjacent to where the triangular excision was, when they did the primary suture repair, they incorporated the cleft into that. And then this is a nice post-bypass image, and you can see that he's got no mitral regurgitation, maybe a tiny jet there. Obviously no prolapse. Yeah, I always have to say he's got at least a little, right? And so a very nice repair. The mean gradient at a heart rate of 98 in the OR was 4 millimeters of mercury. And then here's what his left ventricle looked like, transgastric. This is Dr. Suri, who used to practice with us and was pioneer in our area, in our facility with the robotic approach. Just lend me this slide. This is a different patient, but it just shows you the difference between, he obviously ends up without a sternotomy here, and he has the puncture sites where the instruments and camera went through. So he was extubated after transfer to from the OR to the ICU, dismissed on the 4th day. He did have a little loculated right hydropneumothorax that had to be followed. And he was placed, because of the band, placed on apixaban 5 milligrams twice daily for 2 months, and then he'll be on aspirin 81 milligrams daily. And on his pre-dismissal echo, and I put in the handout if there are images from his pre-dismissal transthoracic echo, but basically he had the typical post-repair appearance of the valve. His ventricle was smaller, his ejection fraction was a little lower, and he had no pulmonary hypertension or pericardial effusion. So beyond the business about doing quantitation if it's available to give you increased confidence in the degree of regurgitation, I think these are just another couple other points as you follow people with myxomatous disease that starts out as prolapse. He previously had a mid to late systolic murmur, and by the time I saw him, he had a holosystolic murmur. So once that happens, or if you're doing echoes serially and he's got mid to late systolic CW signal, and now you're doing your echo and he's got holosystolic signal, even if you can't see a flail segment, you have to be suspicious that something changed to make it a holosystolic signal, and most often that'll be a ruptured cord. And regardless of that, if his degree of mitral regurgitation increases significantly, then obviously his LV will increase with the increased volume overload. So an increase in left ventricular size that occurs after a plateau is a clue that something has happened to the valve, dramatically to the valves. And here's just his, if we look from 2017 when he was first noted to have mitral prolapse to post-operative, you can see that his ventricle was 56 and 30, 55 and 34, 56, 32, and then in between this one, he's referred to us and he's all of a sudden 63 millimeters of mercury. And with that, that correlates with the mid to late systolic murmur on physical exam becoming holosystolic. And so those are just real nice keys, and it's always nice if you can follow patients serially. If you have this kind of table available to you, we have a thing called serial study on our echoes, and if they've had serial echoes, we get all the measurements lined up next to each other automatically. And so that was, those are the teaching points for the case, and it actually follows the nice pathology that Joe showed on myxomatous mitral valve disease.